Albeituni. Thank you so much for sitting down today with the Histiocytosis Association to have a discussion about your recent publication, Differential Effects of Itacitinib, Fedratinib, and Ruxolitinib in Mouse Models of Hemophagocytic Lymphohistiocytosis. I know this is very important work, and the studies into different treatments for HLH are incredibly critical and important for patient outcomes. And so thank you so much for your passion and dedication to this work. I'm really looking forward to speaking with you. And first, I'd love to have you introduce yourselves so that the histio community gets to know you a little bit better. So Dr. Camile Keenan, let's start with you.
Thank you so much for having us. My name is Camile Keenan. I am currently a pediatric oncologist up at Seattle Children's Hospital, affiliated with the University of Washington. During this work presented in the recent publication, I was in my pediatric hematology and oncology fellowship at St. Jude Children's Research Hospital with the fortunate experience to be a member in Dr. Kim Nichols' laboratory where this work was performed. I'm really excited to talk about it today.
Thank you. Thank you so much. And Dr. Sabrin Albeituni, welcome. Love to get to know you a little more.
Thank you. Thank you, Deanna, for inviting us for this. I'm excited to talk about it more. I'm Sabrin Albeituni. I'm currently a senior scientist in the laboratory of Dr. Kim Nichols at St. Jude Children's Research Hospital. And I had received my training from the University of Louisville in Kentucky in tumor immunology. And then I worked with Dr. Kim Nichols in this totally different subject, which is a hyperinflammatory syndrome known as HLH. And currently, I'm very interested in investigating the cellular and molecular mechanisms of disease in HLH, and hopefully, we can talk more about our current work next.
Thank you both so much for your time. So this paper is very important, and I'd love to learn a little bit more about the background. What inspired you to do this work, and then maybe we can dive a little bit more into what you discovered and some of the context of what's inside that publication.
So, as your audience may know, HLH is a fatal hyperinflammatory syndrome. However, we have many treatments for it right now and multiple regimens. But despite the current treatments, 40% of HLH patients die from this disease. And HLH is driven by these proteins known as cytokines, and these proteins are required for cell to cell communication. So, in hyperinflammation, you get these immune cells that kind of accumulate and then they start calling each other more to the site, to the sites in different tissues. And they do call themselves more by producing more of these cytokines, which leads to what we call cytokine storm. So if this inflammation is uncontrolled, such as in the case of HLH, these cytokines are produced in excessive amounts and they can lead to multi-organ failure and unfortunately death. And since many of these cytokines do signal through different proteins called JAK-STAT proteins, and these are important whenever an immune cell does release a cytokine, there is a recipient cell that gets the message, and where the cytokine binds to the receptor, and then that receptor gets activated through the JAK-STAT pathway. So the idea when I actually joined Dr. Kim Nichols' lab, is that maybe if we inhibit the cytokines downstream JAK-STAT pathway, then we can probably inhibit many of these manifestations that are leading to hyperinflammation in HLH. So in the past 10 years, our laboratory has been actually investigating the effect of a JAK1 and JAK2 inhibition with a drug called ruxolitinib. And we and others have actually found that in preclinical models of HLH, if you inhibit both JAK1 and JAK2 with ruxolitinib, we do get amelioration of disease manifestations in these models. Now, ruxolitinib actually is being trialed by us, and we'll talk about it a little bit more later. And there are many, many case reports where doctors have used ruxolitinib in the clinic as either salvage therapy or in clinical trials to rescue people from, dying from this disease. However, with the use of ruxolitinib, many clinicians actually raise the concern of hematologic toxicities, and they think it's because inhibiting JAK2 inhibition might be the reason why these toxicities might happen. So this is what inspired our work to improve on what we have actually found and ask the question of whether blocking JAK1 alone with a drug called itacitinib would be better than either blocking both JAK1 and JAK2 or JAK2 only with the drug called fedratinib. So this question was like the focus of this new study.
Wow, one thing that really stood out to me is you mentioned over the last 10 years the lab has been looking into this inhibition of JAK1, JAK2, and just a reminder to me how some of the scientific work that goes into getting us where we are today with histiocytosis does take a long time, and the commitment of your teams and your lab to continue this work is so important and very, very meaningful. So thank you so much for that background. And so now if we think
Thank
about
you.
the study and the publication, can you share a little bit more about what you discovered, and maybe just share a little bit about if someone were to review the publication, what they might learn from what you learned in this work?
Yeah, so, there's, like Dr. Albertini was mentioning, there's growing evidence that blocking the pro-inflammatory cytokine signaling by inhibiting these intracellular molecules, JAK1 and 2, can be helpful in patients with HLH. However, given that concern for the potential off-target effects like anemia and thrombocytopenia by blocking the hematopoietic growth factors that use JAK2 signaling, there's some hesitancy and understandable concern. So we aimed at determining if blocking the JAK1 alone could confer similar benefits in hyperinflammation. So to test this, we administered itacitinib, the JAK1 inhibitor, fedratinib, JAK2 inhibitor, or ruxolitinib, the combined JAK1 and 2 inhibitor, to two different groups of mice. One modeling secondary HLH, where we use repetitive CpG stimulation, and the other harboring a perforin 1 gene mutation to model primary HLH after infecting with a virus called LCMV. And these effects were not only seen in improved survival, clinical scores, and laboratory values, but also in actual gene expression as measured by RNA sequencing of CD8 T cells and monocytes in the primary model of HLH. So what we found was that while JAK1 inhibition with itacitinib showed some improvement when used in the model of secondary HLH, it was really that combined JAK1 and 2 inhibition with ruxolitinib that was required to have significant improvements in multiple disease parameters, such as those that I just mentioned, the survival, the clinical scores, laboratory measurements of hyperinflammation, and even the gene signatures of the cells of these mice, that were required to have those improvements when used in the model, especially of primary HLH. In addition to that exciting finding, I think it's also important to note that although JAK2 inhibition with fedratinib did not perform better than itacitinib or ruxolitinib in either of these disease models, it also didn't confer any overt toxicity, and in fact, it significantly improved the anemia in the primary model of HLH, for example.
Yeah, and I would like to just like follow up a little bit on that point. And that tells you that these diseases, like when we talk about MAS, which is macrophage activation syndrome, I know for the rheumatologist, I like that you're using that term as well. So with that, like it has, of course, like many other groups have shown that they have a different pathophysiology, right? So it's not like one treatment fits all. So it's good. Our work like does suggest that you have to treat people based on like their pathophysiology itself. Like you can probably use itacitinib for a secondary model. Like in this is in mice, so we haven't uh, done it in people for now. But like the idea is like you have to balance and in which type of JAK inhibitor you might use depending on your patient and the patient history as well.
That's very exciting findings. I know, treating HLH is difficult, and there are some therapies out there that have been helpful, and this idea of being able to use these inhibitors and have the low toxicities is really, it's exciting. And seeing this in mouse model, what does that look like to go from a mouse model to clinical? I know ruxolitinib is currently on trial, but maybe, I don't know if that's part of the future of where this publication and your findings and where this future will go. But maybe you can speak a little bit to that. Like, what is the future from here? How long could it potentially take for this to be something that families can try?
Yeah, such a good question. I think we're very close. I think, like Dr. Albeituni mentioned earlier, there's fortunately a lot of great publications from across the world that have already implemented the use of ruxolitinib in a wide range of different patient ages, underlying etiologies with HLH. The use of it widespread within the United States, of course, will take some longer time for regulatory mechanisms to be approved. I think pursuing the ongoing trial, HLH-Ruxo, run by the North American Consortium for Histiocytosis, is really important work. And I think continuing to enroll patients and see what great outcomes and benefits we can have on that trial will fuel the process for eventually getting it approved for use in other patients with HLH. So still a few years away, but I think we're getting closer, and it certainly helps when people share their experience from all across the world with use of these different cytokine inhibitors in this rare patient population.
I do believe, yeah, we are living in hopeful times as well. It is time to get that 2004 HLH protocol revised. There are many exciting studies, not only from our teams, but from many in the United States and all over the world to try to find like novel inhibitors and, more targeted therapies for both MAS and HLH. And these are really hopeful times indeed. And hopefully in the near future, we'll have more options now, not for only like HLH as like a first line treatment, but also for refractory HLH as well.
It sounds like there's a lot of future, positive implications that this work will lead to. Is there anything that's next on in your labs where you're looking to kind of take the findings of your study and this publication? Is there a next step from here for you, or anything else that you want to talk about related to the publication itself that we didn't touch on?
The idea for the next, I think I just want to like kind of zoom out a little bit from all the studies. So basically, we and Dissan Bassi in France have found initially that Roxo has an effect in preclinical models, and then we followed up with a few studies, including comparing it with a blocking of interferon gamma in primary and secondary HLH models, and then we followed up with more studies on whether combining it with dexamethasone would be an option, right? Or combining it with anti-interferon gamma blocking antibody would be an option. And now this study highlights the difference maybe between um, inhibiting JAK1 versus JAK2 or both in both models. So I think now we have like this more broad picture of what is happening with JAK1 and 2 inhibition. And we are fortunate to be in a time where St. Jude is actually, like Camille mentioned, we are running a clinical trial. Dr. Kim Nichols and Dr. Melissa Hines are leading a multi-institution phase 1B and 2 or slash 2 study to determine the effect of including Roxo in the treatment regimen, right? And so the goal now is to see what the effects are in these patients. So we are actually working in St. Jude and other institutions to further analyze these samples and see the effect on on patients, not only on preclinical models as well. And hopefully, we can understand its mechanism more in people.
Yeah, I agree. And I think that seeing specifically the differences in gene expression profiling in our work, I imagine will inspire some similar profiling of patient samples, including those involved in the HLH Ruxo trial, that can really help us learn more about getting back to the pathophysiology and therefore the highest yield novel treatment approaches for HLH and how that might look different for different patients.
Yeah, definitely.
Very exciting. Thank you for doing what you've done so far, and it sounds like you have some incredible ideas for the future as well. And with HLH being such a progressive condition, and I know that having really good therapy and intervention is so important. It's just amazing to know, like you said, Dr. Albeituni, we're in hopeful times, and it really feels that way. And it sounds like there's so many people collaborating together to make this happen, which is also really feels really amazing to the histio community as a rare group of rare diseases, and for HLH, specifically, it just feels amazing to know that you're all doing this and working together and sharing what you're learning. So thank you very, very much. Is there anything else that you'd like to touch on? Anything at all related to this topic, or anything you'd like to share with the histio community?
To say again, like, thank you so much for having us and giving us a platform to share the results of our recent study. As you mentioned, this specific histiocytic disease really has not seen dramatic improvements in patient outcomes in over 20 years. And so publicizing any steps we make towards improving outcomes is really, really valuable. And I hope that this will not only inspire patients and providers to get their patients plugged into clinical trials more and more, but also inspire some willingness to expand investigation into other cytokine blocking agents and combined therapies. Just as a field, we're attempting to see if that more targeted inflammatory control can be achieved compared to the historical use of the chemotherapeutic agent, specifically etoposide. So we're excited to be a part of that effort, and thank you again for having us.
And I would like to add like a little thing. So it's from a feeling I had when we last met in the Nacho during the Nacho meeting at St. Jude. It's like seeing the families, because sometimes we do in the lab, like sometimes you need that inspiration, right? So seeing the families did. I would like to thank everyone, like the patients, families, and providers, and know that your hope and resilience are very, very inspiring for us to do more of, hopefully, help even one child to survive is like a big uh, gift. So, of course, we aim hopefully to one day. You never stop to dream that maybe HLH will just be something chronic that you just treat or maybe eradicate it. Who knows? The future hopefully is promising.
So much for those beautiful words, and so much for the work that you're doing. It's really inspiring and so meaningful that you both really have this much passion for it. So thank you from the bottom of our hearts and on behalf of the Histio community. And thank you for taking some time too. We'll include the information for the publication so that families and providers can look into that as well. And we look forward to keeping in touch with you to stay on top of the great work that you're doing in the future as well.
Thank you so much. Thank you so much for having us.
Thank you, Dina.